So, anyway, so you may notice I'm not full yet. I'll try and do my best if I don't feel ever live up to what standards of chairing this meeting or a style. So try and keep going through it to see how we get on. Keep you nice and good. So I'm Will Taylor, I'm the GP and chair of CCG. Just to note that all of you, as we've just done, we are webcasting this meeting for live and subsequent broadcast. Obviously, can't raise hands like we would on Teams. So if you want to speak, just raise your hand and let me know, and I'll bring you in. And members and public may record or take photographs except where there are confidential items or exempt items. I think there is one exempt item on the agenda. Members are reminded they must declare any relevant pecuniary and non-pecuniary interests arising from any business to be discussed in this meeting. Or if a disclosure of pecuniary interest is declared, the member must not speak or take part in the agenda item. Any declarations will be recorded in the minutes of the meeting. I believe we've got a few apologies from Councillor Hamilton and Matt Bennett, and then Sus and Kay, Chief Superintendent Graham, Carly Jones, Patrick, Referrals, Professor Robin Miller has submitted an apology for the names, and I think we are expecting Dr. Barney and anyone else.
We've got sorry.
Okay, thank you. And then one piece of information is going to be exempt, so to highlight reports and appendices in which officers have identified as containing exempt information, so we'll do that as private. Within the meaning of section 101L of the Local Government Act 1972, officers consider that public interest may be maintained, but the exemption outweighs the public interest in disclosing information for reasons highly important. So, for item 15, there's two items which is the Health and Wellbeing Board. There's two items that we'll probably take to private session, which is Appendix 1 and Appendix 2. So I could have asked, are there any matters that members would like to raise on that the exempt appendix that may affect the decision being made, or to ask clarification on any point on the exempt appendices? And if no, the meeting will carry on to consider recommendations in private session. Okay. Past that. So that in accordance with regulation for local authorities, meetings, regulations, the public will be excluded from the meeting during the consideration of those two appendixes from that piece, and we'll let you know when that is. As I said, as exempt on the ground, it is likely, in view of the nature of the business to be transacted or the nature of the proceeding, that the members of the present public were present. There will be disclosed of exempt information. Which says, okay. And also to know the dates of the following reports for the municipal year 21-22 as follows. Ongoing is the 18th of January 2022 and the 22nd of March 2022. So, the first item to thing is to agree the notes of the informal meeting held on 27th of July 2021. So is everyone happy with those notes? Then on to page 8, 9, 10, 11, 12, September. We got it. That's in the
Yeah.
So pages 5 through 22. take 5 and 6, 7 and 8, 9 and 10, 11 and 12, 13 and 14, 15, 16, 17, 18, 19, 20, and 21, 22. So is anyone with any issues around those? The action on to the next item. So we'll pass on to 8 and 14, the programme officer, to go through the action on. So on to my update, which I'll sort of try and do through. Again, I've never going to speak with Councillor Hamilton on this. So it's really nice to see everyone face to face, which is, I think, the first time we've done this in a very long time, isn't it? In terms of Wellbeing board. And it's really lovely to be here. I think the health and wellbeing boards, in many ways, were one of the first iterations of us trying to do that piece of integrated working between health and social care, and really tying together those strands of looking at the wider determinants of health and how we work together as a system rather than individual parts of the system. And actually, it's really lovely that reflects today. So something close to my heart is food. But actually, the item we're looking at today is a superb illustration of what we've been doing over the last few years. Something that really is so simple, and actually something we do every day, eating to keep ourselves healthy. And yet there are so many misconceptions, misunderstandings, and the impact of this can be huge, whether or not you're eating good nutrition, eating well. And that's not just the impact on health, it's the impact on mental health and food, the impact on society. So it's wonderful to see that piece come through. And also the piece around social prescribing. So both items really working to tackle those wider determinants of health, which is great to see on this. But again, equally, we're sort of going to listen a little bit about Better Care Fund and how we're using that to better support the health and social care system, especially on items like discharging patients from hospitals. So we improve the flow through our hospitals, but also give them better care when they leave and get out of their own homes. So they really illustrate what we can achieve as a health and social care system when we work together. And I think through this, we're still looking then how that translates through into improving the care of our citizens within what's happening over winter pressures, what's happened during the last 18 months or so, quite longer around COVID, how we deploy vaccination. And actually, I think one thing I just wanted to really say is how well I think you can see the story progressing through the Health and Wellbeing Board, the Better Care Fund, the work we've done over the last 18 months in looking after COVID, the winter pressures work and the work around early intervention, and aging well, to the development of the ICS has been brilliant. And actually, you can really see how narratively we started bringing together those threads in a coherent way, and I think really sets the tone for how we want the ICS to work across Birmingham and into Solihull. So I think that is fantastic, and I think there is credit to all the members of the Health and Wellbeing Board really to laying the foundations of that, which is wonderful. And also, I just really want to take this opportunity rather than the chair to make sure I thank everybody, because the last 18 months has been hard, and it's been the work of not just the NHS staff, not just the social care staff, but the work of every single member of the public in Birmingham, Solihull, to try and prevent this vaccine, to look after each other, to get vaccinated, to protect themselves, but also to protect each other, to wear masks. There is some uncertainty at the moment, and I'm sure people got to find about that, about the future and what's happening with COVID, with the advent of yet another new variant. But I'm sure we'll all come together, as we have done over the last year and a bit now, to do our best to make sure that we work through it and work through this winter to have the best possible outcomes for us all. But yeah, just thank you very much to everybody. So think I shall move on. And there are no questions. And I know Dr. Khan has got to get away very quickly, so we're going to go to your items. And we're going to move the agenda around a little bit and bring your items forward. So that's the coronavirus decision statement, and then we're going to do your Commonwealth Games update, and then move on to the item around the healthy food city. All right.
Thank you, Chair. So I'm going to try and join the Teams meeting so I can present the slides for you on the COVID update, which I've just been trying to update when they were done yesterday morning, because as you know, it's a rapidly changing situation, but I thought it was helpful to take you through this presentation, which summarises roughly where we are at the moment. So, in terms of the shift from the previous position, hopefully it will come up on the screen any minute through the wonders of technology. Let's try again. Where we are in terms of the current position is that we are seeing case rates staying relatively stable. They're not coming down, which is what I would like to see. They're kind of stuck. And alongside that, we're seeing pressures on the NHS, pretty much stuck. And they're pretty similar to where we were back in the early summer in terms of the COVID pressures. So in UHBT at the moment, there are around 120 patients still as inpatients. We haven't been, over the summer we saw those numbers come down and back up again, which is somewhat frustrating. What we are seeing though is a real reduction in terms of the number of people that are dying, and the patients that are in hospital are nowhere near as sick as they were in the summer. So there are significant signs that the vaccination programme has worked and is making an impact in terms of deaths, which is good news. In terms of the policy shifts that we've seen, the arrival of the new variant is complex. This is a new variation of the virus. What we know at this stage is that it is more infectious. We do not know yet whether it is more dangerous, i.e. does it put more people in hospital and does it kill more people? The reason we don't know is because the population in Africa, where the variant is now predominant or emerging most, have a very, very different baseline health, and it's a much younger population. So it's quite hard to judge what this virus actually, this variant means for us in terms of the UK. Their vaccination profile is also different. What is emerging is a sense that the vaccines do work in terms of protection against Omicron, and then the booster is more important than we thought against Delta. So what the booster is doing is boosting up the number of antibodies, and that can overwhelm the variant, even though it's not a perfect fit. So that's why there's been some shifts this week in terms of the national policy on boosters. It's been announced to accelerate booster dose now being eligible to all adults, and the time frame between your last dose and your booster being reduced from 6 months to 3 months. The NHS is working hard, as I'm sure Sharon will comment on, but to increase capacity as fast as possible, alongside the vaccine supply chain being increased to match that demand. There's a lot of work going on about that. The other thing that I think it's important to mention is that there is now a bit more clarity for people who are severely immunocompromised. So these are generally patients who are under active chemotherapy or aggressive immunosuppression. So those individuals are going to require 4 doses of the vaccine. So there's been some confusion around the letters that went out, saying whether people are asking, is this a booster letter? No, for these patients, they need a 3rd dose, and then they will probably need a 4th dose as well. And new guidance, I think, came out earlier today to the clinical teams, but it is a very small group of patients for whom that applies to. And that's because the nature of their treatment is that their immune system is not as good as people that aren't severely immunocompromised. There have been changes on travel guidance, and it's important that people travelling do keep an eye on what's happening with the red list. And I imagine that we will see new countries added to that red list if Omicron does spread further across the world. The case definition continues to evolve, primarily focused on travel history. At the moment, the vast majority of cases across the world are located in a small number of African countries. We have seen some cases now clustering and being identified in Holland, but these are all located and linked to travel. What you will have heard in the media is talk about ST target failure. So if you remember back when we did Delta, we had Alpha and then we had Delta. So the difference between Alpha and Delta was basically the computer said no when it came to this thing called NextGene. So it was originally thought to be an error, and then it was identified that that was a way, it was a proxy for understanding Delta. With Omicron, it's a bit more complicated. The bit that the computer says no, that identifies a fault, is a bit more specific, and not all of the labs yet have the technology to be able to give us that proxy. So it's slightly different from what we've been looking at for Delta, but it is still associated with the ST. But it's what's called ST target failure. People who are identified have to isolate for 10 days. All their household contacts, including children, have to isolate for 10 days. And that is irrespective of vaccination status. So we are being quite aggressive in terms of the follow-up and the isolation of this. There's still not, this is still being very much managed nationally. There's a small number of cases across the country. So at the moment, it's still a national operation. There is no plans at the moment to step up surge testing in the way that we did around original cases of Delta. So we're not planning Operation Equal Time approaches for those of you that remember it from previous waves. Our overall picture, as I said, is relatively stable, and there's been a slight increase in the last week or two, very much reflecting increasing case rates in 5 to 10s and 10 to 15, and in really unvaccinated populations. As more of the population is vaccinated and boosted, the virus is running out of places to go. So it's really mixing and spreading in the unvaccinated populations. The evidence base still suggests that younger children, although they may get unwell, very, very few end up severely unwell. However, the JCVI is considering and looking at the evidence base and the business case, or the medical and ethical case again, for vaccinating younger children. And I expect the JCVI will probably revisit and announce further updates on their position in the next week or two around younger children and vaccination. So I will circulate the slide afterwards. It's similar to what is produced on a weekly basis through the local outbreak engagement board. I think the only other thing I would highlight from this data pack is that where we're seeing the highest case rates at the moment are in the most affluent parts of the city, particularly in Sutton Coldfield. And what I think that is reflecting is that the areas of the city that were hit hard over the most recent wave during the summer, which was predominantly the east, the west, and the central belt of the city, have natural immunity. And that combined with vaccination is in effect behaving a bit like a booster and giving them an element of protection. The big question mark is at what point does that natural immunity run out? We know that natural immunity doesn't last more than a year, and in some cases can be as short as 3 months. So the big question mark from the point of view of the implications for the system, and particularly for NHS colleagues, is at what point is that natural immunity going to fail, and will we start to see surging cases again in areas of the city where vaccination remains still lower than we would like. That being said, I have to say the vaccination programme is doing a phenomenal job. And when I last looked into the data, the fact that we're over 80% of over 70-year-olds have had their booster and are double vaccinated is amazing. For a city that has really struggled with this, with getting vaccination levels up, we are doing really well. And most of the city now, in terms of the most vulnerable population, over 50, are now double vaccinated, are now moving to boosters as well. When you look at our overall vaccination data, it doesn't look quite as rosy, but that's because we've got so many children. So the moment they start making vaccine eligible to younger age groups, our percentage of coverage drops quite dramatically. But as I said, I am most concerned about those over 50 and those with clinical health problems, and vaccination in those groups are doing well. Finally, just to say that testing coverage is maintaining, and we're seeing pretty stable rates of testing. There's some up and down when it comes to school-aged children, depending on half term and school holidays, but otherwise testing rates have remained very stable across the city, and that's a reflection of the population remains pretty engaged. Looking forward with Omicron, we're focusing on messaging, encouraging face coverings. There is currently no evidence to support working from home or cancelling mass gatherings. The emphasis is strongly on get the vaccine, because the vaccine allows us to function in society as normally as possible. Over the next 2 weeks, I think we will get a much greater understanding of what Omicron does in Western European populations. That may change things, but I'm hopeful that all the evidence to date suggests that this is something to remind us and keep us aware that COVID hasn't gone away. But actually, if we keep going with vaccines and we keep going with basic interventions, we should be able to manage it and navigate what's coming next. Happy to take any questions from the board.
Any questions you've got flying on that side? No? Okay, we'll move on. So, I mean, this does nicely lead into the vaccination update. We've got 5 minutes to go. We'll probably come back to so we'll move on to the Commonwealth Games.
Yeah, so in terms of the Commonwealth Games update, I know you had a presentation from Mary, one of my assistant directors at the last board, who took you through the general overview of the Commonwealth Games. What I thought I'd just focus on today is talking a little bit about what we're doing from a public health perspective in terms of legacy, and the 3 strands of action that we have around the legacy programme. So the first is in terms of active lifestyles, and the focus there is on increasing active travel, particularly in our ethnic communities where we have some of the lowest levels of physical activity. You'll be aware we ran the campaign Toga Time over the summer. You remember that was a briefing that came to the board in the early summer. That was quite successful. We're looking now to build on that, but pivoted slightly to address the concerns from the communities around road safety. And really, having heard and engaged with communities, that's one of the big barriers that's coming back, is people don't feel particularly safe. So really pivoting that campaign to talk about how can you be active out, walking or cycling and keep safe, particularly in the winter when it's dark, and being more conscious about road safety. We're also in the process of commissioning a piece of work with our universities to look at culturally appropriate translations of the Chief Medical Officer's guidelines. So one of the challenges we've heard from communities and also from clinicians is no one really understands what you mean when you say moderate physical activity or balance and strengthening exercises. And if you try and translate those using Google Translate, it gets even more confusing. We did a piece of work during COVID with Aston University where we looked at COVID guidance for I think it's Arabic and Somali languages, and that very clearly demonstrated that direct translation word for word is not appropriate when you're trying to communicate complex, potentially complex or abstract messaging. So part of our legacy piece of work is to take the CMO guidance and commission academic partners, linguistic experts to translate the pieces of work. The methodology we use with Aston, we're looking to replicate, which involves communities in that co-production of the translation. It's a really interesting methodology where you bring academics together in communities to co-create how do you explain this and how do you translate guidance in a way that's meaningful. The third element of the active lifestyles program is around the integration of physical activity into clinical care. And I'm not sure whether Richard and Sam know this, but we are coming to the Inequalities Board with a proposal around how we take the work that Public Health England had done several years ago on physical activity with the clinical physical activity champions, moving medicine resources, and really accelerate the education and the embedding of healthcare professionals across the breadth of healthcare. This is not about saying GPs, we need you to have group advice conversations. It is much more about saying, actually, secondary care consultants, really important to have these conversations, pharmacists, nurses, other healthcare professionals, dentists. So we're really maximising that messaging across the system. And the Sports and Exercise Medicine Registrar who's working with at the moment is leading a workshop that proposal. The plan is to start with ischemic heart disease, so we take the pathway and work through breadth of the pathway, but then to rapidly replicate that across other chronic conditions in the run-up to the Games. So there's 3 elements around active lifestyles. In terms of healthy eating, and I'm sure Sarah will mention this when we go to the work on the food programme, but we've gone to market, haven't we, Sarah? Now we're about to go to market to commission nutrition experts to look at the Eat Well Guide and do a similar piece of cultural translation. Many of our citizens have a sense of what healthy eating is like and what it should be in the context of their culture and their heritage. But really trying to do this in an evidence-based way so that we've got that resource. One of the other elements of that piece of work is looking across the world at what the countries promote as healthy eating, particularly Commonwealth countries. And we have a series of students on placement with us who are doing that as one of their development projects during placement. We have a conference that's planned as part of the Commonwealth Games programme with small and medium enterprise food retailers. And that we're scoping with them, particularly around how can we support SME food businesses healthier. But that's part of the Commonwealth networks that links across the world, the food systems work that we're doing as well. The final strand of activity is around more general health and well-being. So there are some structural things we're doing around trying to be a smoke-free games, making sure that the food environment that the games offer is healthy and culturally appropriate, that we try to influence the partners of the Commonwealth Games around health and sponsorship. Many colleagues will remember the 2012 Olympics hosted the largest McDonald's in Europe. We're trying to avoid that for the Commonwealth Games. But it is a challenging environment. The sponsorship of the Games is really fundamental to its delivery. And frankly, not a lot of businesses have got a lot of passion at the moment. So we're navigating through that and working with the council because it's important that we practice what we preach in terms of developing that sponsorship framework. The other important strand of legacy that's being developed is around health literacy. Last year has really highlighted that as a city, the levels of health literacy are too low. When we went out and did vaccine engagement, we were really going back to basic primary school biology in many systems about understanding their body, understanding basic immunology. What is the vaccine? What is an antibody? How does my body defend itself against infection? So we're in the process of developing a program of training, predominantly e-learning to begin with, in partnership with e-learning for health and health education England, that we plan to pilot with the current COVID champions, then expand to the Commonwealth Games volunteers before building into a programme that can be expanded across our voluntary community sector. But I think it's a really exciting legacy. And of the legacy pieces, there are many bits that we're doing, but that's the one that I think is a step change piece for Birmingham, because if we can become a city that puts health literacy at the core of our citizen empowerment across the whole system, we will fundamentally change the way that people relate to the health system and relate to their own bodies and their own health, and that has huge potential to gain. So I think that's a helpful update. I thought it would be useful to really focus on those legacy programmes as they develop. And as we move forward, we will bring more formal written updates to the board.
Thank you. I mean, I think my point of view, that sounds fantastic. Piece of work, actually, some real legacy items there as well. When we cross over beyond the boundary, we use a long tail to the Commonwealth Games that actually would be beneficial on the really interesting around that translation piece. That actually has a much wider doesn't go through a number of programs, including some of the inequality work around program examination, which seems so basic, so sensible.
Manny, you want to go first?
I think you introduced yourself when you, yes, so my name's John Freer, I'm a GP and chair of Birmingham place. Just last time we came, we had a Commonwealth Games up there, we talked about legacy in terms of children and their engagement with exercise and the ability to engage with a sporting event that was of this status. You said that you get involved in general practice, but that's got in touch with us. We've been doing some really interesting work with schools in this area now. Talked about last month, about these starting to start that discussion around immunizations and the right benefits. And we're very practical. So I'm really keen to engage with schools in a meaningful way in the setup that we've already got. So I hope that there's some way that we can feed it onto work or to the health work. I think it's really important space. I suppose the other thing is children don't really know what Commonwealth Games is, and so that whole process hasn't really started. And very much it's 8 months away from having an event at that stage of the decision. It's that comms campaign that is really important.
Doug Sink is Medical Director of the Community Trust. Just a couple of observations, I guess. We talked about road safety, but park safety is also something that kids have brought up. So I don't know whether park safety has got enormous green kind of assets, but they're often not used because people are scared, children are scared of using them. So whether park safety is part of the plan. On the translation, I've been struck in a kind of research past about the advantages of easy read documents. So translating patient information into easy read. Actually, most people took the easy read option. So in the translation, is it as easy read as possible? There's 4 points. The third one is the activity stuff you talked about, Justin, sounded like making every contact count. Now those 4 words mean different things to different audiences. But I'm really keen to kind of reinvigorate making every contact count in a nice sense within my organisation. And I'd quite like to extend it to make every contact count in relation to poverty alleviation if you're in a situation where poverty is clearly going to turn. And I'd really love us as a system to, because I think there's public health expertise in making every contact count, which is different to NHS expertise. And I'd really love to co-produce a suite, because I kind of have this vision of a health visitor with a kind of superhero belt on, and they just plug off, or GP plugs off the suitable making every contact count for this consultation. But that requires kind of joining it all up. And the last one is, our librarian talks to me endlessly about the importance of health literacy. I'm sure she would love to join you if it's something that you would welcome. I had a penny for every time she said health literacy to literacy.
If you think that,
Yeah, so I'll pick up this before Karen comes in. So, so Manu, in terms of the schools, so the reason I didn't mention it is because it sits under DFE lead. So it's being managed nationally, some of the schools engagement rather than locally. We have a new director of children's services, Sue Harrison, who started a couple of weeks ago. And the West Midlands GP model, working with schools, was shared, and I forget how I got it, but I sent it to her when this is brilliant. How do we take this and build on it and think about it? Because I think it's a really good model. And there are other parts of the country who have variations on it. So I think there are 2 different bits. I think in terms of comms and schools and games, it's ramping up next term. So that's when you'll see it in the schools. But I think in what you're already doing in terms of partnership with the schools, Sue's very keen for us to sit down and have a conversation about what does that mean in terms of scale.
Oh, yeah, sorry, I didn't talk to you. Where we go here? There you go. Do you want to talk?
Yeah, just take much minutes to leave it's really, it's really good to meet you all here at Birmingham, seriously. I'm the substantive director of children's services in Birmingham, and it's great to be here in the partnership. I'm intending to be a substantive member of the school, to bring whatever I can to support partners around the table. Obviously, health and wellbeing is important for everyone, isn't it? Children don't exist in isolation. existing families and their existing communities. So it is important to work together to try and back on commitment to that. But like you, when I came 4 weeks ago, I've been asking about what's happening when it comes to schools. And behind the scenes, there's a lot of work going on, which is reassuring, which will, as Justin said, kick in next term. So there has been school planning, but it does need to, unfortunately, because you're quite right, children need to be engaged, and it's a wonderful opportunity. We're also asking the question what the legacy is for our children and families, and it would be a shame if we just nice events and then there was no one legacy and no real opportunity to create that. So, thank you very much for that question.
Apologies, I didn't see that.
I didn't agree with what you were saying, so
That's always good. Just to come with your points, Doug, about yes, road safety is car safety as well as people walking and cycling is a really important point. And you know, I think it's interesting as a city, we haven't really talked about a number of children that are killed and seriously injured on our roads, yet we're about 29th worst in the country out of 150 authorities. You know, it is a problem in Birmingham, and it's something we don't really talk about. So I'm hoping through this piece of work we can start to bring that conversation out a little bit more, because I think we should be talking about it. My hunch is we don't talk about it because most of our children aren't killed, so it's not coming through the child death panel, but they're seriously injured. And that has a whole series of implications both for children, the families, and for the wider system of health and social care. So it is very much dropped on my, we need to do this. In terms of the MET point, you're right. I see MET and health literacy as kind of two sides of the coin. They're not quite perfectly matched. And there have been things in the city that have been done before on MET. It didn't land. It seemed to be very bitty. And that's one of the things as we move, I'm hoping, into living with COVID in the new financial year, we will refresh that approach and really start to look at what is in the toolkit. One of the things that I'm kind of pausing a bit on the MET side is trying to see what is the future of e-learning for health, and what is Health Education England doing, because we've looked at, I think it's the Northwest, that have a really impressive MET platform where all the resources are well placed, it's really well signposted, it's brilliant, and it's run by Health Education England Northwest. And I said to them, well, we have it here, because most of this can be lifted and dropped really quickly. But because HE is now merging with NHS England, there's a lot of, you don't know who's here, who's there, but it is on the plan. In terms of the health literacy, yes, linking into librarian, more on board the better. And it links back to the point that you were saying, what we really learned through the last 18 months of COVID is that as a system, we need to do more to help citizens and patients understand their bodies. And a lot of the fear, a lot of the mistrust is that we still treat medicine like magic. And actually, we assume a level of science and basic understanding of biology, which I don't think, and Sue will correct me if I'm wrong, but I'm not sure it's quite the same in schools in the level of detail that it was maybe when we were all at school. So there's a kind of level of assumption of what people have. And those of us that did biology all the way through, because we went on to medicine, have a kind of completely different view of the world's understanding of human biology. So the health literacy bit, I think, is these are both slow burn pieces. They're not going to solve the cost pressures tomorrow, but they are pieces where we've got to have a much clearer strategy across the city.
So who else have that hand? Karen.
Karen Halliwell, Extreme Cat, but I'm also based on CCG. Thank you, Jessica. It's really helpful to hear all the various implications. I suppose from my perspective, if we were going into a challenging winter, how do we get the right comms and the right priorities through to stakeholders that we haven't picked up these are the three messages and the three things I would take away today and make sure we engage with GPs and district nurses. I just worry that with all the challenges we're facing at the moment, we don't want to lose that enthusiasm. As you said, Commonwealth Games, it's really understanding how we get that focused enthusiasm and actually looking at how we get that directly to us.
Yeah, I will. I'm loath to try and share the screen again, so I won't. On Thursday, and this will come as left field to members because we've not got the briefings out yet because we're still locking down people. You remember during the first summer of COVID, we ran Be Healthy. Because it's very simple. Here are kind of a checklist of things you can all do that just make you a bit healthier. And then there was kind of a massive slide deck of web links that you could look into each thing. So we've taken Be Healthy and we've turned it into Be Healthy Winter is Here. So basically we've stuck a whole load of snowflakes all over it. But we've also put in things that's specifically about winter. So we've taken a bit of the COVID messaging out. The systems have told us they're fed up of us talking to them about COVID the whole time. So there's a bit about COVID in there, but it's not the headline. The headline is winter's here. There are things you can do. Make sure you review prescription requests are in with plenty of time, that you're not asking the GP to do it last minute. Have you got some tins of soup in case the roads get icy and you can't get out? Is your meter tucked up? Have you got your winter fuel payment if you're eligible? There are things like that. And then there's also the everyday checklist of have you spoken to someone you don't live with today? Have you been and had a walk or done some physical activity for 10 minutes today? So we've updated Be Healthy and turned it into Be Healthy Winter is Here. And that will be launched on Thursday evening and with a refreshed set of resources. And I think a very good point, what's the ask now? The ask is for all partners when we get the stuff out to you this week is to help us amplify it. Because that gives really, really simple things. The translations will be ready at the end of next week. So like we did the original Be Healthy, we'll be translating it into about 16 different languages. And there will also be a BSL version being produced with our partners as well. So really direct people into Be Healthy. We try to make it simple and clear at this time, but also bring out some of the things we specifically want at winter. We've also added in elements about how to use your NHS. So your GP, don't use your GP for everything. They're great, but there are lots of other healthcare professionals in the system trying to help some of the signposting and navigation there as well.
Thank you. Fantastic that GPs are great. It's really important to use the system. There's a lot of this comms issue raised a few times. So just in terms of amplification, is there any means for you to do that? Is there something that we can help?
Yeah, so the comms teams are now meeting primarily on COVID, and then there's a kind of slightly separate group that meet regularly. So we are powering into it. And one of the challenges is because COVID is just so fast moving, trying to get comms headspace on anything that's not COVID comms is quite challenging at the moment. What I want to ask for board members is to bit that reaches communities is your personal and professional network. Whatever we put out on the VSOL Twitter account, the council Twitter account, those bits will be sorted. Not worried about that. But the reality is that most of the population don't care. That's not where they're going. But they do look at what practice websites put out. And that's where the ask is about individual organisations putting the hyperlink on, promoting it through your own networks, because that reinforces, if you get that across the whole city, that's the comms application that matters. And the comms leads struggle to do that at the scale of the city. They're not getting down granular, I think. So that's my ask on comms, is to help us get out to more specific setting networks.
Any more questions about that? I mean, it sounds like this is a whistle stop forward. I think people are bring back more details. So the next thing will be we'll just all need to support this. It sounds like.
So next item is creating a healthy food city forum. So you guys want to do that? Yeah, come and join us.
It always feels in this room like a cheap seat. Always a challenge.
Well, first of all, I know you received a big report because it's a very complex big area, and I want to make sure that if there's a particular thing you want to refer to, it's available to look at. But within this, I will be presenting it in a much more simplified take-home message format. So, the shared vision of the Creating a Healthy City Food Forum is to create a bold, healthy, fair and sustainable food system and a prosperous local food economy where food choices are nutritious, affordable and desirable so all citizens can thrive and achieve their potential for a happy and healthy life. So it's quite a big mouthful. It's because food systems are huge and there's so much that you can do at so many different levels. So I'm Sarah Pullenbow, I've got to the description at the start. So I'm the new food system lead at Public Health. So the service starts at the end of August and our team is complete by the start of October. And in that time, we've now got 3 key members of staff and also graduate officer support for particular projects. So in that time, we've had 2 creative food systems, 3 Healthy Food City Forum meetings. So the first meeting was in October, where we already got an outline of the food system strategy, and we wanted to make sure that this captured everything that people had brought to the table before. So one of our first actions was to synthesise all the things that have been happening over the years. There's lots of things that have slowed down because of COVID. There's huge amounts of insight reports, feedback from various organisations across the city. So we really reflected on that and pulled it in the national and international literature about really good food system strategies and created an outline for review in October. And then between October and November, we developed a fuller draft, so now we've got our initial draft that is being used as the stimulus for the pre-consultation sessions. So we've got a broad agreement on the work streams that we've decided, which are in the report as well. And in January, we're going to be having workshops, 2 workshops a week for a few weeks through January, to strengthen each of those work streams and also to start developing the action plan, where we will see the translation of these ideas and strategic priorities into real what does this mean for citizens. We've had agreement just this week to move the cabinet approval to March instead of the initial January that we're planning, and that means the public consultation will be in June. So that means we've got more time to do really strong pre-consultation sessions over these coming weeks, which I think will really be great as well. So I think the main summary of what the strategy is about is that we've had feedback from various people across the city. First of all, citizens tell us that they need food that is affordable as well as nutritious. Cultural diversity is key, and messaging around food initiatives, and so one needs to take account of this hugely diverse city we've got, and also to celebrate that, because this city is amazing. We've got huge amounts of varied food and cultural backgrounds, and that needs to be really woven into any initiatives we develop. We also need to improve the health of diets and food available across the city. Also, community organisations have told us how there's far too many people struggling to get enough food, and they can't feed themselves or their families. And there's also too many people with a lack of knowledge and skills to cook healthy meals as well. And businesses have told us that it's really challenging to make healthy food an economically sustainable business choice. And they also recognise it's food waste. And this pandemic has revealed just how fragile food security is, and it's really exacerbated the inequalities in many communities. The people that suffer the most are the ones that could not take that hit. So we really want to address that. So we're striving to create a healthy food city where everyone can access healthy, sustainable, safe and delicious food every day. It shouldn't be at the cost of enjoying food. Food's what brings communities together. It's what we do every day. So understanding that it's a part of life, but how we can shift it to change what types of food while still maintaining those things. So we're going to need action at every level of the city in a true partnership approach. And the recent food forum meetings have been amazing because everyone's truly coming together to come up with new ideas and solutions. So there's 3 key actions that we're delivering with this strategy. First of all is to create an economically vibrant food business sector that provides affordable, healthy, delicious food that celebrates diversity in the city. We also want to work with our community and voluntary sector to mitigate the impacts of poverty on food security and maximise the uptake of support programmes such as Healthy Start vouchers and free school meals, and also to support those community organisations to connect and to carry on with the amazing work they've done over the pandemic. And also work across the life course to support people to make healthier choices about their food in their lives, from weaning through to moving into independence and adulthood, and then also into later life as well. So how we're achieving this is we're really looking at the city from a big old city approach. So we're looking at the action through a city-wide lens and making sure that the people who need it most are being considered, and really addressing where there's inequalities or barriers that need to go from specific groups, specific actions. We're really looking at how these things affect them. We're also looking at the places that need the action most. For example, there's places where they might not have access to some of the resources, the services, the stores, the shops, or the types of initiatives that are in other areas, making sure we look geographically as well as people in communities. And also looking at the different types of settings and the role they play. So there's things that the council will be able to do. There's also plenty of actions that will be able to be taking place across the city, whether it's youth centres and schools, whether it's doctor surgeries, other medical settings, pharmacies, shops, different community groups. There's any type of setting we're building into this big old city approach to make sure that we're really thinking about it from all sorts of angles. And the framework for action has been delivered across 8 key areas. There's food sourcing, food transformation, food production, food waste and recycling, food economy and employment, food skills and knowledge, food behaviour change, and food innovation partnerships and research. And this is more as a way to structure the very vast array of factors that are involved with food systems, and making sure that we bring people together on work streams where there are overlaps. But a really key tool that we've introduced is the food action decision making and prioritisation tool. So what we're doing is, rather than having a separate work stream for inequalities or poverty or sustainability or making sure that people are empowered and so on, we're taking these this map tool and making sure that every single action that we put into place considers these factors. Is this addressing it for people who need it? Is this what citizens need? Is it celebrating diversity, addressing poverty and inequalities, health and safety, sustainability? Can it be scaled up? Are we learning? Are we being risk aware? So every single action we take will be considered with those points as well. And the hope is that we can improve and strengthen any actions, as well as address where we might be looking at something that could be shifted the focus. So, in addition to the food system strategy, we're also working towards a sustainable food places award. There's key criteria that we can work towards to make the city more sustainable. So we're bedding that into our food system strategy and our general approach. We're also aligning the work in Birmingham to national strategies, such as the National Food Strategy, and also international work, such as the Milan Urban Food Quality Pact. And there's some amazing work that's happening internationally. We're making sure that we're really on the forefront and adapting to those things. We've also attracted a huge amount of food system innovation to the city. So the Mandala Consortium is a multi-million-pound project that's happening in the city that is completely, well, it's using Birmingham as a test city, really. It's looking at food systems from all angles and working out what type of solutions might work, testing them, reviewing them. So it's a hugely complex program that Birmingham City Council is part of that conversation as well as many partners across the city too. Birmingham has signed the Glasgow Food and Climate Change Declaration, which is a commitment by national governments to tackle the climate emergency through integrated food policies. So recognising the role that we have to play within the food system. The food system in Birmingham is huge. There's a huge amount we can do to support these things as well. And also, as part of our work representing Europe on food justice, we're leading the development of a political statement on food justice for cities to sign and work with us on. And this aligns with the Council's commitment to right to food, and it's also more specific to food justice too. And it means that we're really looking at the right to food for all citizens and the challenges people face across our work. And in addition, we've been continuing to deliver the Child Abuse and Child Related project. So that included the Healthy City Planning Toolkit, which is now being written and shared for consultation feedback. And we're now speaking with other planning colleagues to see how it can put into the development plan and how it can be embedded so that health impact assessments are conducted on all sorts of planning developments across the city. We're also doing some insight work with Birmingham Food System Exploration. So this kind of works in parallel with the Mandala work, but we're getting really insightful feedback from Birmingham food businesses about what the challenges are to making it economically sustainable, healthy food offer, and how we can support overcome barriers there. And then we've also been developing and beta testing a health literacy course for apprentices and agency. And I know that any insight that we capture from that process will be able to feed into other health literacy courses too. And separate to that, we've recently started to ramp up our work on food poverty as part of this Right to Food, and also the amazing work on the food justice network across the city. So our aim is to increase access to affordable food and strengthening the networks across the city that already exist, and having that almost making every contact counter-based, where anybody that sees somebody in a food emergency knows what to do, who they're concerned to for help, and what solutions there are in the city. Because I think a lot of the barriers is communication with so many small organisations doing things on the ground. So we're working with the Food Justice Network and the Active Wellbeing Society to look at how we can smooth the system around to make sure that everybody gets help as quickly as they can. And as just mentioned, we're developing culturally relevant eating guides with the Commonwealth Games. So that will be, we're looking, with the nutrition specialists, we're looking at whether the boundaries that we propose for the cultural areas, whether it's geographic areas, or how the culture should be framed in terms of how many different types of guides we need. Developing videos linked to that, and also developing initiatives and campaigns that can be rolled out in communities to capture recipes, get people to share recipes from different Commonwealth countries, and really celebrate food over the Commonwealth Games in a way that's fun, and it's almost help by self. All these things are going to accidentally be helpful, but really what you're doing is you're enjoying food and celebrating the Commonwealth Games being in the city, and seeing how all these different aspects of the city with the big multitude road can take this on as well. So, I mean, that was always the stop tour of what we're doing, but yeah, I think the main take-home messages is there is a draft outline of the food system strategies, and we're doing pre-consultation sessions, and we welcome people joining the workshops through January. We've got some Google polls that are available that people can sign up to particular work streams they're interested in and contribute to that. If you're unable to make any of those, we welcome conversations outside of those as well. Also to note that Birmingham signed the Glasgow Food and Climate Change Declaration, and we've made pledges with regards to the right to food and our plan to act on food justice and embed this, if we can, to other health and wellbeing work streams and make sure we're all coordinated with our approach. And then also we're reviewing how we need to tackle poverty, because we do have currently a food poverty core group that come together to discuss it. But now that food poverty is being so embedded within the food system team and our approach and strategies, making sure that we coordinate with folks across the council and the health and wellbeing board to tackle poverty and inequality in a way that makes sense. So basically we need to review what the systems are and how we're making these things happen to make sure that we avoid duplication with the loads of people in the amazing way, but also strengthen our approach. Thank you.
Thank you very much. I mean, that's a piece of work. But obviously hugely worthwhile. Inspiring so much from the game, how we and actually people understand the whole and understand the implications of nutrition. So it's fantastic. So, any questions on that? Yeah. So it's really comprehensive piece of work because yeah. What does success look like for you in this program?
Well, we're developing, as part of the workshops in January, we're developing, we want to capture what measures people have in the city as well, and what indicators there are that we might not be aware of yet, which ones we can develop and strengthen, to make sure that we're not just basing it on knowledge that, oh, I spoke to somebody, they said this, but seeing how we can systematically build it in. So with the, I think our initial aim is to develop a really core action groups. So the strategy will be from 2022 to 2030, and we'll have review points to consider, are we achieving what we need to do, and what can we do to address our aims. I think that's all going to be developed as part of these workshops in January, because we really do welcome any contributions that people have to really capturing success. Have you got anything to say?
I'm a healthy person, so apologies for this. So, the obesity, 1 in 4 of my kids in this family were obese, 1 in 3 have habits or abuse, possibly diabetes or lots of diabetes. These things are absolutely linked. So it is one of the months to successfully less abuse children.
So in decades, yes. In the next 3 years, no. So shifting obesity is at a population level takes decades. There is nowhere in the world that shifted it in anything less than a decade. It requires whole system action. And what we'll do with big strategy is start that journey, because what we can offer at the moment is weight management. There's a whole innovation program going on around children's weight management, because the evidence base on what works for children is so bad. But there is bluntly very little, or it's very hard to put someone through a weight management program and then walk out onto the Soho Road and be surrounded by high fat, high sugar, high salt food that is cheaper than healthy food. Parents have quite actually told us that they are fed up with being told their child's overweight and living in an environment in which they have to basically drag their child past temptation every day. So this kind of work will take quite a long time to play back on the obesity data. But if we don't do it, we're never going to solve the obesity pressures that we've got. It's impossible. So yes, when we continue to track obesity data, but the correlation between what we're doing in food and the outcome will probably take decades.
There's something just about the responsibility we have to tie all these things together. So tripping with schools and super interested in this is that we mentioned COP26, we talked about air pollution, we're in these we've got the worst air pollution in the city, and we've got the highest accident rates in the city. We're asking them to do more exercise, and we're asking them to do an environmental pollution so high that it's going to be very risk. So I think that kids probably have part of the answer here. So they get the schools like this going to be key, and anyway, this will be primary parents that we would be doing that, and then you would do it at face level. Is the idea it's highest deprivation area, one of the highest deprivation areas in Birmingham, and that's the highest level of free school meals in the area. You figure out the holiday periods because the deprivation is so high. So actually, I think
so it's worth saying some of the work we're already locked into East Birmingham, which has a similar case, and that's partially we wrote it into the East Birmingham growth strategy. So you remember when East Birmingham growth strategy was out of consultation, we wrote into it. We want to create a healthy food economy in East Birmingham. So some of the economic growth work will be piloted and developed there. What is also outside of scope for Sarah's team, but sitting with a different team in my department, is trying to do some work on mapping the obesity pathway. So there have been a series of workshops which were held by some of the pharma companies looking at what's going on. And I sat in on one of them with a lot of bariatric staff who were really quite frustrated that we haven't quite got that right in the system. And I think there's a real opportunity in the shorter term to look at some place-based approaches to weight management and really trying to make sure that the pathways that we have are working systems, and we all understand who's commissioning what. It is quite a fragmented pathway, but also joining that up. So I'm hoping that mapping piece of work will be done. And whether we bring that to the next board or we take it to one of the subcommittees, I think Karen, it might be useful to have a conversation offline about how we position it, because weight management commissioning is layered, and I'm not sure in the ICS world where it's going to go, but it's a real opportunity. All through the inequalities might be the other case to take it. Because I think while we do the structural stuff, that's great, but we've got children and families that are struggling with their weight today. What we haven't got is a coherent pathway. We've got lots of bits. And I think there's a real opportunity to try and bring that together at pace while we're sorting out the structure. And that, I think, has to be place-based. I think there's a lot of it too.
That's really true. We should use the social services like do a lot of things change. Then Richard into there.
Yeah, I think it's I'm Richard Shepard of the Community Healthcare Trust. I think it's a really helpful piece of work. Having been asked by my children as they left home this morning if I minded if they went to Big John's on the way home from school, you can see some of the kind of the stuff Justin's describing. I said no, but I don't know whether it will have any effect. Is kind of a bit. But to pick up Justin's point and then to make an offer of a connection, I think probably trying to think through those weight management pathways probably fits well in the prevention or bits of the inequalities work programme, I think, in terms of who we've got gathered where. So I'm kind of happy to pick that up with Ruth and take that forward that way. But the couple of connections, Sarah, we'd like to make, I think, is our Birmingham Forward Steps Early Years services we run are in touch with lots of families, so this will be really important. And our community nutrition teams, I think, are also really keen to help. So if we can get in touch to make the contacts with the right folks, I'm sure they'd be really happy to help.
That's great. We've made quite a few connections just from my team is very chatty, so we seem to be collecting people at the moment, and we're now trying to galvanise that and really get a really interactive map and understanding of the city as well. But yeah, we certainly welcome conversations as well. And I just want to raise as well that my background is changing the eating habits of children and increasing the diversity of diets and tackling the eating and doing it within schools and settings and understanding the barriers to why children eat what they do, not just what. So we're really building that into our approach.
Thank you, Solomon, the Health and Inequality Programme Director for the ICS. And just to build on what Richard was saying, this interconnectivity course is absolutely key. So it's a fantastic presentation. Dr. Franklin says the connecting the inequalities aspect of this in areas is absolutely key, because we know a lot of this stuff has been around for years. It's not news in one sense, but we also know that inequality is actually widening. It's not just that we're standing still, going backwards as a life expectancy. Given what the youngest population we were right here in Birmingham, what we're seeing history is actually starting out in the age. So the link between health literacy and schools, and we know that's the power works. You know, when children get something in their heads, but no attitude towards smoking has changed very rapidly because young children have learned about the effects of it. So we can change attitudes, we can change behaviour. So I'm glad to think about making it into a wider determinants. Obesity is actually a normal reaction to a very abnormal and unhealthy environment that many of our youngsters don't have a choice in being around. And that bit, no matter how well educated those families become, no matter how well they become people, that bit is the wider system. Whether it's licensing, I know again there's been lots of talk, I know we've got certain agreements, but I haven't seen it implemented. In fact, what we're now seeing is not just more flight food places in most deprived areas. We're seeing now this stripping off dessert places, all lovely, all very tempting. And part of that is symptomatic because people can't get other jobs. So if you haven't got qualifications, if the job market is into people are starting these businesses. So what is the system's response to, A, if you're going to have a takeaway, keep mandating some of that restriction, so that there's a big bunch there, but also on the positive side, what are the incentives and how to that link, so that we can actually create a healthier environment that once we do into the clinical bits, we can ensure longevity sustainability.
I mean, it's certainly a hugely partnership-based approach as well. I hope the health and city planning tool supports this process as well. I know that a huge issue is the fact that lots of these places exist already. So, trying to overcome that when they're already there. But the thing that some of the insight work that we're working on, for example, the dessert places, the reason, in my opinion, that they're doing so well is it's a social venue where people can use something that isn't too expensive and they can have time together. So when you understand that the driver for people going there is actually they need somewhere to come together, and is there an alternative, healthier business version of things that could address that, still make them a profit, still address the fact that people want somewhere to meet, that they're too young to go to a club and costs too expensive, there's not youth centres or youth clubs to go to, and it's looking at things where some of it can be outside the range of my team, but really proposing these solutions and saying, in this community, the reason this place is really popular is because it's a centre for networking and understanding that that's why it's happening, and you look at it in a different way. So rather than thinking they're going there for food, they're going there for social. So I think, I mean, I haven't got any answers as yet, but I think this food system strategy is really, really to get people from different perspectives. And the action plan will be an ever evolving thing. So hopefully we can learn from what works in other places as well. Just anything to contribute that.
I think the only other thing we just pick up on the point about how you retrofit health into an existing environment is complex, and it is complicated by national legislation. One of the things that I most often get asked is, why can't I fix the fast food environment in the city? We're kind of middle of the pack when it comes to the density of fast food outlets in Birmingham compared to other cities. The problem is that the national planning guidance, and the guidance we have in Birmingham, which is in the context of the national framework, only gets applied when you're applying for a brand new license. If you're renewing, so if you buy someone else's hot food takeaway venue, or you take over the lease, you can change the type of hot food you're delivering, but it's not a new license, it's considered a renewal. So the guidance we have around supplementary planning guidance, which is now part of the Health and City Planning framework, can't be applied to that because the legislation stops us doing that. And that's one of the things through the work in charge of this Trailblazer programme we've done. We've been saying really loudly to government, we need national planning laws changed so we can apply what's called saturation policy to renewals of licensing as well as to new ones. And that's one of the things that I think we've got into a very different space when we're looking at food from other parts of the country, is because we are looking at kind of how do you make fundamental change, not how do we tinker at the edges, because otherwise we end up continuing having a city which creates an environment in which it's easier to be fat than it is to be a healthy way. But there are some of those things are really getting into the nitty-gritty of what the legislative environment is. Similarly, we can't use business grants to stimulate healthy food environments. So we can use business grants to stimulate particular sectors of business, but the legislation around them stops us doing it when it comes to food retail, just an anomaly of the national guidelines. So again, we said to national, well, why is that? Why can't I use a business grant to incentivise a greengrocer, for example, but I could use it to incentivise a clothing store? And they're kind of going, well, we don't know, it goes back to when it was done to begin with. So we're kind of unpicking that with them. But those are the kind of spaces that we're getting into in the food conversations. And I think that is really exciting because it fundamentally means we are going to change the environment in the city. It is going to take us time, and we've got to get short-term things in place as well as long-term ones. But I think there is a really, really positive future coming out at the end of that.
Brilliant. I think that's a huge, huge piece of work. It's going to take place over several decades. I think we can change some of the fundamentals. Hopefully, we can change a huge amount over that period. So I think there's two things. One is actually you probably need to help make sure you engage with your role in the short term. So obviously, we're a partnership organisation supporting with that. The Health and Wellbeing Board was actually asked to recommend to endorse the outline of the draft system food strategy and contribute to the pre-consultation, which is back to shape the final draft. Note that Jim Birmingham has signed the Glasgow Food and Climate Change Declaration, so obviously this goes way beyond just what we can help, it's the health of the world as well, and has made pledges regards to the right to food and our plan to act on food justice and embed this in the other health and wellbeing work well, and also to participate in the upcoming decisions on how to tackle poverty across the city responsible for eating food policy, call group workshop and consultant recommendations. So is everyone happy to agree with that? Yeah. That's much manual. Thank you. So just move on. So I think that's all your work. Thank you. Is it one?
I'm afraid I've got to get back to my.
Thank you so much for coming.
I've got to favours on this. Thank you.
That's fantastic.
But yeah, please do anyone get involved.
Yeah, and if you need us to circulate information, our workshops
yeah, I'll send through those and I'll have one contact. Thanks so much.
So I'm just going to quickly ask Chris Clark to introduce himself, because I believe Darryl just told me it's your first meeting as a member of the
Health and Wellbeing Board of Directors.
Yeah, it's like, my name is Riaz Khan, the senior leader for the Department of Work and Pensions, and I focus on vulnerable customers and safeguarding, so making sure the department's policies and procedures, particularly making sure most vulnerable customers are not unfairly impacted by our policies and procedures, and feeding that back into our street level to make sure we do all we can to provide the best service to our customers.
Thank you. Let's just, I'll point out your first idea. So if we just move back on the agenda to a couple of brief updates from Karen on the vaccinations and the ITS.
Thank you, Sharon. I'll keep the vaccination update brief. Obviously, not trying to go into some of that. Since the last meeting, it's worth noting that the immunisation and vaccination programme is now led by Sarah Jane Marsh, the Chief Executive of the BSOL, for kids at the Birmingham and children. And again, it doesn't just cover COVID vaccinations, it covers childhood immunisations as well. So I think that an overview of all of immunisations and vaccinations will bring a great amount more depth and strategy across the East. In terms of where we're at the moment, obviously we have over 23 PCO sites working on the boosters. We're still offering the first and second doses, and we've got over 25 community pharmacies for all of operations. So clearly, with the national announcement this week, boosters extended, as we said earlier, the vaccine working through the implications of this, and obviously how we add that additional capacity to deliver those new areas. There's some operational guidance that we need as well, but obviously a huge challenge for the system as well as West Birmingham as well. The majority of our care home patients have received the booster. There are some exceptions, those that have COVID or are not eligible. And obviously the housebound patients of our community trusts and primary care are working really hard to complete as soon as possible. We're trying to co-administer with flu. We don't want to forget flu equally in this process, but obviously that isn't always possible. But obviously we really want to push the flu administration as well, which obviously is a lot more focus as well by the group. So there's a weekly review looking at the low performing areas, focus on those outstanding house plan. Workforce is a real challenge, as we appreciate now with the administration of not just the vaccination programme, but the other aspects of the plan care that the machines have as well. And also the communication strategy. Vaccine fatigue is here, and we need to make sure that we do everything we can with partners to improve that. That's a whistle-stop tour through rooms and that.
Just a couple of questions on vaccine. It's just not going on, just really need to keep pushing them, especially with this surge, haven't we, around in terms of pushing the boosters now, the arrangement. Okay, so shall we move on to the ICS?
Keep it equally brief, for some time. So in terms of the ICS update, in terms of our current arrangements, obviously, as you know from the last meeting, Paul Jones retired as our accountable officer of ICS, chief executive. We currently have interim arrangements in place as we do into the system with the ICS chief executive. So many of you will know David Melbourne, who's the interim designate ICS chief exec, and myself as the interim accountable officer until March, and obviously Richard, who's chair of the provider group. So it's working together, I think, over the next few weeks across all parts of the system. A lot of work is underway around the infrastructure of the ICS and the ICB. So the appointment of the non-execs to the ICB is about to start the next round, and we're still going ahead with other aspects of the new organisation in terms of getting on with the appointment of the directors. So a lot of the infrastructure is going ahead, and again, a lot of work about the constitution and the membership of the various boards. So that ranges from the partnership board through to the NHS ICB form in place. So a lot to work with, quite a complicated set of governance, but really important to get the right numbers around the table. We shouldn't forget, and I think nationally the expectation is the ICSs all need to focus on the here and now as well, use the partnership work to work around urgent care, which is a huge challenge at the moment, and the planned care, the number of people who are waiting for an operation is significant. So that backlog of cases and the urgent care is clearly a massive challenge in working through that as the ICS is going to be. I won't go through all the other work streams. I'm sure we'll come back with a more detailed report. But obviously, you have compressive brain vets and occasionally on place. I think you're going to mention it later on in your section, and lots of work going on about the transition through to the Western Inequalities Board, obviously, that's now established, and lots of work around the vision values. So that is an extremely quick piece of structure where I was making a chance.
Yeah, so that's a huge amount of work going on behind this, not really fascinating. So, I mean, I know we've heard a lot about guys, so I'm saying that the reason why this is. Any questions or any queries about what's up to the ICS? And rapidly developing and changing processes.
I think it's just worth mentioning, isn't it? We've referenced it a few times, is that there's still work to do, and there's a massive amount to do, and there's massive organisational change going on. I suppose it's just a keep citing that you will be able to do that work, the organisation stuff, but also needs to be done, but both kids will have to find some bandwidth to do those things. And I suppose we should prioritise the work stream.
Yeah, I mean, it's a huge piece of work, as of people and everyone involved, but at the same time, it's trying to manage the current yeah, the future seems to make sense, and we can do it well. To have a well-structured, functioning ICS that's built collaborative work we can do in the so yeah, absolutely. So any other questions about ICS? Good. So when we want to leave, let's get on. Errol was like, just helping with this in terms of when we stop the right session for the stream. So, which point? I think some of it and some of it's going to move. That's right. So, you would like. So they're interested in one. Do you want to try to? Right, okay. So, yes, so we're not forward. So, shall we move on to social subscribers? So, sorry about that. Come to you in a bit, everything. Council Thompson, we need Council Thompson here before to hear that piece of that right decision. So, we'll move on to social subscribing. Okay. So, you said you social subscribing. Sorry.
I just wanted to share correctly. Again, it said Alex Ferguson was attending.
My agenda says Alan, so mine's right.
All right, okay. It's really enthusiastic. He's a close right.
Yeah. Go on then, folks.
There is a sex license on that. I don't want to risk the IT, and I don't think on that side it's really.
I was emailed out for them.
Yeah.
So if you haven't,
yeah, so you should have it. Essentially, I'm just briefly going to cover the objectives. I'm going to go through a brief part of the silent purposes and move on to support and board. So essentially, the social scoring system that we have now forms good connection between surgery and the voluntary community sector. And what there is an ecosystem to make sure that the things people need are in place. So there's a type of previously, we then have this type of responses in place in the voluntary sector and CCT. The objectives of the approach are to improve patient outcomes and to balance social prescribing activity so that this contributes more to system integration, We also try to incorporate in capacity violence and social screening repairs, to capacity building, support the management so that's the broad. I won't go through lots of details of the paper, but I'll just have a outline that the price operating in the paper.
Yeah, thank you. Really, there are three key areas that we want to achieve over the next 18 months. In terms of the revised operating model, it's one I'm calling it a reset model because, unfortunately, the social prescribing system didn't get off the ground as quickly as we wanted to because COVID came into play literally a couple of months after most of the social prescribers and the system was due to go online. But over the next 18 months, the plans are, and the hope is, to look again at the data that we are extracting and look at the gaps in that data and services that are out there so we can make sure that there's a good link between what happens in the PCNs and the activities that the social prescribing workers and the patients can access. So hopefully, the aim is to have something more rigid in place by the 1st of April next year. Following on from that, two areas that, well, one area, but two parts of it that we really want to tie down is a bit more of a proactive social prescribing approach to a single cohort so that we can literally focus and target the activities around a single cohort. That will make the system, I think, work better and will be also easier for future consideration. And that is something that we want to have in place by 12 months from now, towards the end of October this year. And 6 months after that, we'll be in a multiple approach to those cohorts or several cohorts of commission.
The reason this was so that the approach session for you is very sensitive what's in terms of systems around. The two things that we use are system apps and making more effective understanding of where data is like systems and also support the establishment of integration of partners within the ICS. I've been speaking to quite a lot of partners around system. I think it's quite strong. Certainly, there's the beginnings of people trying to rework their structures so that the BCC systems can be used by the health service. I don't think that's something that can necessarily be delivered in the immediate term as part of the ICS direction to get us.
I mean, that's, yeah, I mean, one of the things that people are doing help CCG and USC and that's partnership working which is fantastic. So any questions on this?
Even though we have a new member from the DWP, we still have the right to work program to help people get back into the workplace. And certainly people with challenging conditions, mental health problems, chronic diseases. We were never really able to get to a data set on who we want to support, who the people receiving benefits and how we want to support those people to get back into the workplace. I wonder if that's something that social prescribers actually, social prescribers seems to have some different strands to it. One of them would be get people back to work, and they were good things for people to do, and other things we talked about exercising, all those things. But I just wonder if there's an opportunity here without new guests that are new member to look at the workforce for people that are.
It's interesting to say that because I'm new to the DWP, but my background is social prescribing from Hertfordshire. So I was involved in setting up social prescribing structure in Hertfordshire with a range of partners. And one of the things I've done early in this role is linking social prescribing around the very thing we're talking about, which is linking in self-prescribing with employment and getting back into employment. So yeah, that's what we're actively looking at, working with the social support system. But one more question to you guys, just around that though. One of the big challenges we found in Hertfordshire was around the concerns about COVID, and then that knocking impact of social supply again, that setting it back again, you know, just all the risks. The second thing was around the fusion of people waiting in the system, and how people waiting longer than, you know, a very long time, we continue to wait, and then the deterioration of health and how social supply will support that agenda. So those are the kind of areas that we push.
Okay, so there's a couple of things there. So the way the social prescribing system was set up previously, there wasn't a strategic lever for directing it a particular issue. So now that this is going to change, you can align whichever activity is with the partners. I think that would support if you wanted to run it with work that would be some type of conversation. In regards to waiting, one of the challenges of the previous systems was just no method for understanding where the gaps were. There was no local group city with the going to be restricted. It's not currently very clear where there are patient need that isn't being met around social surviving. And then the need for a system like this is really there because at that point, conversational conditioning structure saying what are we going to do to the capacity of the mind to meet the patient need in the different parts of the system. So hoping as this comes online, yes, we'll identify those challenges, but we'll have a way of addressing them.
I think the system challenge around, you know, how you check the population uptake as well. One of the, you know, all the differences parts of using different systems, and that's going to be a very long term.
And also, we can't forget that the basis for the social prescribing is the PCNs, and they will have cohort of patients depending on the area of the service that they will want. And it's not necessarily priority, but they will be the ones that will have to be dealt with for the benefits of that PCN, or as we're going forward, we might see a stroke of heritage. So we have to bring all that into the conversation.
No, I've seen firsthand the impact also size we have on some of my patients actually. And they're only limited access we've had to it now. I don't understand that. I think it's a true game-changing program potentially if we do it. And actually, one of the things this is a certainly paper, isn't it? Because we did bring this to the Wellbeing board now, and one of the reasons we took it out was actually wanted to hear much more from the concept and how it's going to be straight in. And I think it's really, really impressive now about how it's working. There's a few things you wanted to say. Sorry, any more questions?
Just how to know, just in such employments on your where you made then. There is a DPP program that's delivered by the council called the Spirit program. So happy to send the details of that around the board. It's that program is very response mutual.
And you say more
Yeah, I would say that thanks. It's great to see this report by the Wellbeing board for the discussions. One of the things we talked about in the paper is our integrated commission. First, this was the PCA dissolved money from the local authority as went up, or it's a different pot of money that can be integrated to make sure.
So I think it's actually more complicated than just integrating different budgets. So depending on the structures and the challenges that are being faced, how the outcomes of the different funds, this might look like making sure that activity is aligned. It might look like making sure that we want to use each of the structures and what they structures is going to map to the and it might look like the development of the ideas to move forward. Some budgets that are integrated, sort of shared, and I think it's like this thing. elements of the work, all that stage phrases, you're not even at the stage that the process needs to exist. But it's just to support those integration. One of the frustrations for contraceptive partners is to being pushed to an approach where everybody thinks that a piece of work is a good idea, but something else should pay for it. So they certainly that's a way of having a more straightforward conversation process.
Yeah, I think that's really helpful. I think it's a really good example of well-being, work across the strategy of voluntary safety. So I'd be quite keen to share for us to have a report back, we agree when it's going to come back so we can see we've got the principle. So what about some of the details? I think it will tell us a lot about how we actually do work together.
So that's a reasonable question. Not quite sure how timescales how we do that because actually we probably want to see more work on the ground. So it might be human to
Just linking it to co-production with communities. Social prescribing is one of those things that everyone says is great, but doesn't necessarily get the funding and doesn't necessarily get embedded with how we do business as usual. And now with this new landscape of ICS, how can we do it differently? We know the evidence base is there, so it's not about having to find to prove the case about return on investment. Again, with the utility-based system itself, it means having to top slice budgets from within it. Once that external money runs out, what are the mechanisms in place to do that? That's one question. The other one is about how we ensure that, how we're prioritising what interventions we want our social prescribers to do. So what is the evidence base for that? Looking at the JSNAs, are we looking at local partnerships coming together to identify what the inequalities in those areas are, or is linked to the PCMs, and have a much diverse requirement around local neighbourhood inequality action plans. So from that perspective, if it's all about reducing the avoidable variation, is it aligning to that stream for which certain guys in the Commonwealth Games is committed to? And lastly, how can we do this in a way that really empowers communities? So that upskilling isn't just about the person that's being intervened with, as it were, but people doing those interventions, how can we ensure that they're recruited and trained and upskilled from the most deprived parts of those areas? So the workforce begins to reflect more on local communities, but also going forwards, we've got that skill base being built up, which will help our prevention workers and more as well.
to agree. Some of that, I think, will be honestly place-based working, thinking about how we tackle how inequalities in place and how we really engage with communities in place, especially around neighbourhood which go beyond the PCM desert. It's quite a go beyond the neighbourhood levels. It's quite a isn't it? So, if they want to do
just to add to that, I think the reframing of budgets and the devolution down to basically people that flexibility and freedom is a key part of the transition. The silo working and some parts of the it's maybe selfless, so the ICS has a clear plan to work that through and agree how we devolve it to integrate teams or doing the opposite. We all know what happens when it doesn't. So I think that's the ambition and success is to be ICS to managers to do that with all the sector and other partners. So it's definitely a key priority.
Things you want to study about what success looks like in the different countries. Success in this one, to me, does feel very much about actually how does it feel to work in neighbourhoods, to work in the community, how does it feel in that community connected to the community. I've always said that's good to me because it's a real market to me that this is really working. It's very positive to look at. I know
I was going to make 2 points actually. One of them was I think it is time to be creative, so top slicing budgets to say if we are committed to managing health and quality this is an opportunity for us to do that and invest in it properly, which I think is the way to reduce that workload overall. The second thing is about the workforce. And I agree with you completely that actually our workforce, the NHS workforce, should reflect the communities that it comes from. Actually, schools are a great opportunity to entice people, entice children into an environment. And actually, we've got lots of different jobs in the NHS. You know, we employ about 12-15% of the population at the moment. You know, the NHS is the biggest employer in Europe. So it's an opportunity for us to engage with children at a young age to start saying, actually, think about a career in medicine, pharmacy, being a paramedic, you know, being a healthcare assistant, whatever their skill set enables them to do, we should encourage them to do that. But from our, most of our communities, it's the ideal place to do.
Currently, audio is not very good for some of these articles. I know this is not very keeping three more. We could say apparently it's okay, so we also need to project in all of the companies. So brilliant. So I think any other questions from that? It's difficult to see the whole room. I like people. Some people are behind. So, right. So I think there's a couple of things coming out of that. So we've been asked to support, note the funds of faith and support the provision of a system map to enable more effective understanding where data informed capture on social priorities will be raised, which is essentially what we've been discussing in all terms. And also the establishment of an integrated commissioning by partners within the ICS, which again we talked about around that. So I think we're fairly committed to that. Everyone agrees. Brilliant. So I don't think we're able to move on to the Better Care Fund. So should we move on to the Birmingham Children and Young People's Transformation Plan?
The refreshed transformation plan. This is the final year of our 5-year transformation plan for the children and people's mental health and social health. This is the Birmingham aspect. I'm Angela Brady. I'm Angela Brady. I'm the Deputy Chief Medical Officer of Birmingham Social Health CCG, but I'm here as the Chair of the Children and People's Mental Health Transformation for the Birmingham. So I'll just say a couple of questions. Carol will then highlight a few questions and take questions. So don't think we've got long chat. So.
Yes, think it's long.
Okay. So we are clearly don't have the full understanding as to the impact of the pandemic, and that clearly shows in this transformation plan. We don't fully understand the impact that will have on the areas of deprivation, health inequalities, and how much there will be a disproportionate impact. But what we do know is that we need to be agile in terms of our response to this and not forget to do the early work that we need to continue to do. So in that respect, there is some good points that you will see in this plan, and there's some areas of real challenge still as we move forward towards the long-term plan and the ICS. I'd highlight the helpline, which has been a really good new innovation, and that came alongside the pandemic. It was really mobilised our partners in the third sector in a really remarkable way. Things have done that. And also some of the ongoing work with the mental health and schools team, which doesn't have a huge reach yet, but is a really excellent part of practice in terms of that early emotional literacy. We've also seen a reduction in DNA rates in our services, which helps some of our waiting times, and that was facilitated by some of the virtual working that we've seen during the pandemic. So some pros and cons around that. The real challenges, the real downside, I suppose, is around staffing. You can give us as much money as we can use, but we can't use it because we just can't get the staff. And that's having a pipeline and a workforce plan behind that to be innovative in the use of staff, as well as getting traditional roles filled and trained through. So that's an ongoing big challenge. And really, I would add, this isn't in here, but I think this is an interesting point of reflection. I was at a webinar recently with parents, and they were describing how their ongoing distress isn't around the upset of their young person and how that's affecting them emotionally, but it's the impact of trying to fight and navigate through an incredibly complex system, especially if you add on layers such as the justice system or the special educational needs system. And we really do need to support and help our families through this. If you then layer on some of that deprivation and health inequalities to that challenge, you start to think, can we do this? But we can, but we do need, as I say, that real emphasis on balance between crisis and early intervention. So the key to that really is all around emotional literacy, absolutely listening to the users of our services. I know that sometimes can sound politically correct, but it's absolutely essential to what we do. It doesn't take a village to raise a child. It takes a trauma-informed, emotionally literate village to raise a child.
Thank you. So this plan is a system plan. It is a plan before thinking Birmingham. So I think that's really important to emphasise at this stage. So the 5-year forward review set out some clear aspirations around children with needs and income, which was about increasing the numbers, accessing services, about partnership working, about accountability, and increased investment. So what the plan was then, you set out some examples to share, so what's our progress been to date and what we've got to do. So we recognise that. And then obviously the last year of the plan was to be delivered during the pandemic. So the impact of the pandemic that we've seen across the system is the increase in referrals. And if you put that alongside the demands on the workforce and the issues we've got with the workforce, there has been a waiting list. The waiting list is now more FTE, is now down to under 52 weeks, which still is a lot. We recognise that, but actually it's still significant improvement for them. And digital is absolutely part of that response. And what we've seen across the system is some innovation around recruitment as well. So reaching into communities, as we've heard earlier, to develop those links, to develop those pathways into employment. So not just seeking out clinical roles, seeking out that wider workforce in community settings of location and of interest to undertake some of that work. And then that recruitment then is part of our paid training programme. And then when people qualify, they then move to those qualified roles as well, if that's where they want to be. So we've seen a lot of that work happening. And when we move into a long-term plan, one of the asks, or the requirements, I should say, is that the mental health plan, centre plan, and the intervention plans are aligned plans. And that's really important. So they're not just plans of existing separation, that we really do come together and there's a shared plan around that. And there has been good progress to move in that direction. And as Angela said, there's always more to do. The youth offending cohort, the SEND agenda, learning disabilities and autism, we know that those are priority areas. We know our most vulnerable groups and that they are more exposed to poorer outcomes, and that's what we're trying to address as well. So within the plan, excuse me, we detail the work we're doing around health inequalities,
And that's our ability to better use the intelligence that we've got to develop our services. So we have, and in the slide back, you will see that further towards the end of the presentation, the slide back is our inequalities information, where we've looked at it in terms of ethnicity, we've looked at it in terms of access. So we can see who's not accessing our services and what we're doing are further developments. So then not only accessing and having a proactive approach to accessing, what we are then going to be able to do is look at those patient outcomes. So each patient now has a recorded outcome. So to look at reliable recovery. So we then, again, we can look at that in terms of inequalities and demographics, and then look to see how we address that and look at the workforce implications around that. So as we know, the demand has gone up, and you can, FTD at that level are seeing the highest rates that they've ever seen. What's interesting about when you look at FTVs, so everything comes through FTV's Access Centre, but 75% of those referrals do not require mental health intervention, they require a wider support. So we've been doing lots of work around the education system with our partners in the local authority about strengthening that access through work with parents, through work with schools, strengthening that wider workforce so they are better knowledge and equipped to feel confident to hold young people and work with young people and still getting access to that expertise, which is actually the premise of mental health support teams. The resource that we've got, so we've got one established team that's working really well, but that is, and obviously you'll know there's nearly 500 in Birmingham, and that's, we have a new team coming on board in January, but again, that's going to be the similar sort of numbers because the model in HSE design model is for a school population of around 8,000. There is an ambition within the long-term plan that we have 20% of our schools covered. So whilst that might be the mental health support teams in school offer, what we're doing is working alongside our partners to make sure that the education system has an offer of support, that workforce in the school is trained and supported, that there's, so in Birmingham you've got the STIC team, which enriches into school as well. So there's lots of support being wrapped around the schools as well. And as you'll see from the plan, we work really closely with Government Education Partnership as well. And so there's lots of good resources that happen through that work as well. I think Angela's mentioned some of the work that we've been doing around the impacts of the pandemic, which is all on slide 35. Where we are at the moment as well, and I will post some questions, the long-term plan requires us to deliver a 0 to 25 model. Although Birmingham has a 0 to 25 model, the ongoing development for us is about understanding the most effective way for those services to be delivered. And as we mentioned, based on 0 to 25 model, what we've been able to do is look at some of those specialist pathways that require a specialist workforce, or in the case of Solihull, where the numbers are smaller, so it makes sense to have a visa offer. So that workforce would then enrich into Solihull. And we've just done that with Birmingham and Solihull Youth Vendor Services. We've just secured some funding to extend the harmful sexual behaviours work in Birmingham loss into Solihull, because again, they wouldn't be able to financially resource the specialist team because the numbers are so small. So having that visa approach is really good. And we've got examples around the eating disorder service, and then we've got the avoidant food intake disorder, which again is soluble. It will be really low numbers, but as a joint approach, we can do that. So that's what we're seeking out every time. Whilst we're going through this multi-25 development, is looking at opportunities where we can best make the investment to have the best outcomes for children and young people. You'll see from the performance on slide 96 around the access target. That wasn't achieved in Birmingham. It was never been achieved as the trajectory has risen. But this year, we've done some profiling against demand and capacity, and we do expect to hit the 35% target, which has previously been 2 contacts. And HSC we just moved that to 1 contact, so we can all kind of surmise why that was. But it's now 1 contact, and based on 1 contact, we are exceeding that contact. We're not chasing a target, we are looking for quality services, and the outcomes data for reliable improvement is much more meaningful in terms of having an impact on young people's lives. And then from slides 100 to 105, we set out the risks around the delivery of the long-term ambitions, which you won't be surprised to hear are the workforce, the demand, and how poorly people are presenting to us now on the psychosis pathway, on the eating disorders pathway, and then again particularly for our vulnerable groups as well. So we've set out what we're doing, what our plans are around the risks that we are perceiving at this point in time. Now I will take
that. So I certainly have a super question. Yeah, so
Thank you. Well, first of all, I want to thank you for all the progress and numerous skills work going on to support young people, and yes, the challenges that they have. So thank you for that. I wanted also to say, music to my ears about the alignment plans, because I hear that compared to 12 complicated labyrinths that they're trying to negotiate, and anything I can do to help you simplify that, I think it's a good point at time to align those plans actually. So it's something to say. And I also wondered whether I thought about having a particular health offer for Teams 25's care leaders around the health, because I know my professional experience where I've thought is yes, that was a big issue with the veg support going at 18, and particularly with the care leaders. So apologies not understanding.
No, absolutely. Hopefully it isn't good in enough detail in the plan, but absolutely. And what we do is look for sort of those crossover things, so more likely to be homeless, more likely to be known to offensive services, more likely to fall into that exploitation bracket. And so linking into the trauma-informed approach Angela mentioned earlier. So Birmingham Children's Trust has just done a fantastic piece of work about remodeling their services on trauma-informed care. So the more we can embed that around social welfare, embedding it around mental health, and that joins the experience of the young person changes. And that's the work, the trauma-informed work that we're also doing in schools. So from the minute they start to see disruptive behaviour in schools, there's a trauma-informed approach to it, and which is why it's really important that schools do have that information around who those children are. So as we evolve our 0-25 model, we look at our priority groups and the work that we're doing in the Children's Trust around IRA, and I'm not going to remember what that means now. So it's about children who are out of the care system, where they have hospital placements, they are going into crisis, which is impacting on the stability of their placement. There's a service now that wraps around that child and wraps around the placement to make sure that they're getting as much support as possible. So, yeah, it's absolutely one of the priorities.
And it's a subject to kind of deep dive, so we've got this idea.
So I think you did that.
Yeah.
My question is, so I'm basically my son, the most example of stuff. We regularly hear of games where crisis response is not effective, and we get lots of people, young children, young people in hospital beds, where they believe people, they come fast. And actually, they're quite a long period of time. So, is there, can you prioritize your work? Do you prioritize crisis response, or is that the area that
It's absolutely one of the areas of vulnerability. So on slide 57, we talk about the Untitled Chapter, which is Birmingham and their children's with a whole of the Midlands. And what they are developing is a plan, an approach, and it's live now. If a child is in a hospital bed, they have a proactive response to getting them out of bed and understanding what those blockers are, and they will enrich the local authorities to address what those issues are. Now, at the moment, that doesn't happen, and then that's why children end up unnecessarily in beds for longer than they should. We do have a challenge around the crisis response for children and young people. We know that. With West Birmingham coming across into Birmingham, some of those blockers, which are system blockers, that we will then be able to address more effectively as well. We don't have any of that challenges around buildings, and which are replaced and there.
Sample is much longer. Samples are actually so you need to take.
Sorry, I thought you were referring to West
I am referring to West most of my patients are sample West London. They're living patients and that's it.
No.
So that
Yeah.
So place see crisis response on this service.
Yeah, absolutely. Yeah. No. So, let me just clarify that and students here as well. So, Birmingham children receive a response from the Birmingham crisis model. Sandwell children receive a response from the Birmingham model of the Birmingham crisis. Is that what you were asking?
Well, that's what I'm asking. So, I'm basically this one of my kids I take care of ends up in Sandwell Hospital with Birmingham response in Sandwell.
We're doing so much work on that at the moment for all the reasons you've just described and working through some of those sister values and challenges.
Yes, fine. Very positive. See it, but that's fair.
I think there's two aspects to that. There's the boundary issues, right? And then there's also separately how good is crisis response. And there's separate bits of work that both need to be addressed, because quite often what we or a young person thinks is a crisis is not what the system labels as a crisis. The system labels it as distress, and there doesn't seem to be something suitable which will feel like it de-escalates and contains them. And that's something that we're looking at, particularly for our cohort of young people with learning disabilities, autistic young people, because they find it particularly the services don't always respond to the way that they need them to.
Thank you.
So,
Try to be quick because I'm very conscious of my own.
sorry, we're very ready to go. How point were you both very happy with this?
Well, first of all, thank you so much, because I know there's a huge amount of work, and the thought that's came to this is enjoy those trauma informed and really segmenting out with young people, prioritising the most vulnerable. It's really helpful to have some of those disparities summarised more clearly. I know in the slide deck that we did the analysis at CSU did, but there's some really stark information there which isn't necessarily easy to grasp unless you take your time to look at this as people who may not be specialised needs. So, for example, third slide independence, it really jumps out. So when you look at the 0 to 18-year-olds who are registered with their GP with having any mental disorder, the kind of disparities are not small. So in Sutton Coldfield, you've got 31%. In Meriden, you've got 38%. In Surrey, you've got 35%. But when you get into Ladywood, it's 15%. Hodgkin, 14.8%. So that's a massive disparity. So when you're thinking about where do we need to ensure that we're addressing some of that inequity, how can we ensure that in this wider piece of transforming services and care pathways, not losing sight of our starting point, which is very, very imbalanced. Just to add another layer, when that's mapped onto deprivation, it's very, very easy, inverse, know about inverse care law. The fact that it's happening with young people in such an extreme way, it is something which we're really concerned about. But then when you map ethnicity on top of that, it becomes an interesting mix. Because areas like Northfield, some areas in Erdington, which are as deprived as areas in Hodgkin and parts of West Birmingham, and Handsworth. Still, if you're young and you live in an area which, to put it bluntly, has a greater white population, you will still be seen and you will be registered and access. So, for example, Northfield starts at 34% and Erdington 26%. Again, compare that to Hodgkin 14%. We're talking about double digits. And I'll just caveat one last thing in terms of inequalities there. Regardless of ethnicity, regardless of class, as it were, if you are a young person, you haven't got an adult advocating for you, then you are also 50% less likely to get seen. And that obviously has a big impact for those who are leaving care or are in care. So whilst we might have a statutory public responsibility, a lot of those young people want to end up in the criminal justice system as well as in a serious end of mental health disorder spectrum. So just a commentary there, but also an ask if possibly kind of like a summary of here's the reports that you can see from the analysis. There's a lot of deep analysis that I requested more analysis. It's all there. It's just to present it.
Yeah, absolutely. I mean, and the complexity of this is huge, and themes that you're highlighting are items that we have reflected on. It is very difficult because how do you get that universality without necessarily disadvantaging somebody who is very disadvantaged in a more advantaged area or an area of less deprivation. So it is really trying to target the early intervention around some of that welcome quality and make sure that we've got the universality as much as we can in places like schools, and then try to then target some of the specialist work to a more individual need. But it's a superbly complex piece of work to do, and we always welcome increased expertise as well.
It's just a universal portion, universalism.
Yeah, we've had that all the way.
I'd just like to summarise, I know time's pressing, but I thought this was really comprehensive work, went into a lot of detail in terms of the different aspects of it. So I think in terms of the recommendation, it gives good priorities, and I think the challenges are sometimes we feel fully supported and there's more work to do, and we overlay all the other aspects of children through the partnership. I think it's going to be really important. I certainly think it's a really comprehensive piece of work.
Yeah, one quick couple of things. What is that making today?
Yeah. Mental health. Yeah, it's all connected, isn't it, really?
It really is. So yeah, thank you for it. It is a comprehensive, complete piece of work.
I do apologise for not being clear about what our speaking was, but that is helpful. But it is also helpful to hear that it might be add value to having additional health inequality specific piece of work that we can socialise around. Obviously, that will be working with health as well, but that we will take that back.
It's got to be one about policy.
Yeah, absolutely. From the CCG, who use the ICS.
Passport, North people outside, and then just go back to the old way of
Yeah. And I think one dangers is that if we think, oh, it's all been done in this place, in this transformation plan, then we don't own it collectively. So it's how much we.
Said every piece of work that we weaving it through.
Yeah.
It's very exciting stuff.
You know, we had a presentation about social prescribing and talking about primary care networks. So we've got that element, so we've got the education system as well. So we know that we have to in-reach to those groups at the earliest points of contact, and especially within education and the preschool age. And that's why we do all the work around prenatal as well.
Is there any other questions, please? I'm sorry we're running over. So the board's asked to recommend to receive the plan. Does everyone have to receive the plan? And we highlighted it. So what, only guidelines. We are not porous in terms of our elected members to make a decision on the sorry, that's careful. But I'm not sure what you want to do. You probably want to have to move to your occasion.
No, I'm sorry, observation on this. The plan usually submitted to the national regulator to my members. So that's very well. Don't pass ready. But that's not unusual that plans are coming together. Usually, the grace period of a couple of weeks or so. Obviously, the next meeting of this board is January. What might happen is if you could take get the use of board on it, and assuming there aren't any major objections to it, again, the research assurance process that has been discussed with part of it.
Does everyone else have to do that?
Yeah. So, Final Walsh, I'm the head of service for commissioning our social care, and I'm the BCC program lead. Apologies for my colleague. Yeah, I wasn't having. Apologies, my colleague for the system today. As we mentioned, I want the board is the council body for this plan, and we're here for let's get is the only mandated fund for integrated working across health and social care. There was a plan last year, COVID, and the guidance to the plan for the same this year. We had the guidance first of October, so fairly short process around that. Total value, this is a plan which is $2 million, and in terms of the national guidance on the health requirements, we're meeting all those requirements in terms of the CCGs, the contribution, minimum spend on our social care, and minimum spend on alcohol. We hope that made additional contributions in this year, reflecting areas of integrated work across the system. So it's really throughout the course of the year, we've been working on how we better align the financial plan with our integrated care policy priorities. So we've taken some in-depth and also looking at reflecting those areas of joint interest integration agreement. Most of the spending plan is especially around social care packages and hospital care and supporting hospital discharge and patient care. Still manage affects national guidance, so spending on social care packages just reflects that national mandate around the use of DCF really. So the as particularly focuses very integrated work around supporting discharge and in addition to the pieces that I mentioned earlier, are particularly focused around that. Important as we move into my ICS that we have that visibility and ability to analyze the system around this one. That's what we've been really focused on. So just on that theme, supporting discharge, overage program is the activity there, that home first approach to support people out of teams. In terms of the use of the DCF, we're using that to fund important home-stay intervention programs, so the team, short-term base, and third agency that are host pathways, place pathways to the household that accused. See, really, that's really essential in terms of supporting people to turn home, and it's been an area where over recent years as well as seeing increased demand in that area. Some issues can include free institutional work like those and dementia, end of life, personal health budgets, and filling the recommendations through the services perspective is also part of the plan. And really working on a broader use of that with the events at home policy. Few final things to note, issues around policy, the plan, so looking at some of those DCF metrics and just trying to stand those a bit more, get early days around that really, put some clear variations and outcomes. This is an example in terms of the staying acute, but need to better understand that and get under that a bit. In terms of metrics themselves, 5 metrics of time, vulnerable admissions, length of staying acute, stays of 14 days and 21 days. That's a pretty complex picture in terms of data around that. But the sets were around about 50 authorities for part one. Making progress in terms of discharge to all person residents, getting towards that target of 45%. Residential emissions, we changed how we're looking at that issue. Looking at all emissions rather than just those supported by BCC. And similarly, we've revised how we put the variable metrics as well. So using all those people going through the intervention programs are based on for that one. So I mentioned at the start, the plan brings in national experience on the season of the event, and it's heavily improved quality.
Yeah. Thank you. I guess the question is there anything in that including anyone in this room that really needs clarifications in the trial improvement?
Can I say something to that? Thanks, Mike. It's certain papers for the meeting, there wasn't the
Is that not taken to yourself?
So we didn't get all we got was the cover.
Summary report, not like in detail plan.
It said there's going to be vacancies, there wasn't any vacancies, so it's.
Yeah.
So you've done a good job with someone.
Yeah.
I need to see that. So whether or not you could send that out, and say, give us a couple of weeks to come back or something, that might be suited up to wait till January.
Harold, is it okay? Give that.
I wouldn't have there. I think it's because I'm much better, but I don't access full access to the private. So you think it's about our race to conservative.
Yeah. Definitely help.
It might prove it anyway. So, I mean, what do you want to do? Like, I mean,
So
everyone's okay with what you've summarised. So we need to paper and
yeah.
so Harold.
Just to say as a formal part of this, yeah, I don't have any authority to stand and have, so we have got authority to show stand of policies, so we have a formal trust legislation that have been on.
So a lot of the constituents we've got them already, hasn't it? So I'm very aware of that. It's just making sure we take it.
We so that's I'd say that obviously the board will really plan.
We need to do that basically.
So I was going to.
Okay. The good news is they give us 2 weeks back to COVID. So if you go back to COVID, so it's there to share it inside the wall.
I have to say, I can't speak to that. I'm happy to do the demos. Okay, and we'll have to do that.
Take your advice.
So if we take some advice, and see where we go. Is there any other business I didn't know about? Sorry, Reverend. Well, let's ask you to just mention the place in government being developed in Birmingham as a place, and obviously the Hub of England is going to play a large portion of role in the place Birmingham, comparative and Birmingham, so I think probably you'll want that to come back into more detail right in the future rather than going to things in there. If you ask me to mention it.
Well, we request that we have a wide representation from the certain place forward.
Yes.
I think it is important.
I think that's all just keep work in progress, isn't it?
Patient was saying the same thing actually. Why is who is deciding what case is and what it does?
It's been led by Africa's betters, and I think there's obviously a forum that that's going into to just go ahead, doesn't work to make that. There's also obviously a number of items of information in the chat, so just take note of those. And the date and time of the next meeting, as we talked about, Tuesday, the 18th of January. Okay, thank you very much, everybody. Thank you very much. Week is not for that, and this is the first Commonwealth one I've attended in person and had to chair it. Thank you very much, everyone.